Hello, my dear students. How are you? I'm your Dr. Roshini, OBGYN faculty at Digital. So today we are here for your final sprint, your live session, your booster session, your revision session, so that all your important topics with important PYQs will be covered in this session. I hope you attend this and you will take a good benefit of this. So already we are late by 10-15 minutes. I hope we are no further delay and we'll start the session at the earliest. Okay, so today on the day one, so this course is almost for 4 days. First 3 days we are covering the important topics, and the fourth day we are going to give you a test, and this test will be discussed on the day four. Okay, so on day one today we are going to cover about the ANC, hypertension, and GDM. Remember, ANC is equally important. Why? Because ANC is not something like they won't ask. So this is a basic. So basic questions are must, and these days they are more concentrating on basic and your basic knowledge. For example, you are posted in a PhD or somewhere, so how is your basic knowledge? So that is how you will be assessed as a doctor, isn't it? And coming to hypertension, since recently we have so much changes in hypertension, definitely you will have at least 1 to 2 PYQs and sorry MCQs this time, because there is going to be importance for hypertension in this session of NEET exam for sure. Coming to GDM, last 2-3 years I've not seen question, but definitely there was question in last 5-6 years. Okay, and GDM is something where we can give a clinical based history, scenarios, images, everything. So that is why I'm sure GDM is also very important. A brief cover on GDM is also done. Okay, so now let us begin quickly in the first session, that is ANC, the antenatal care. Why do you want to care for an antenatal woman? Just a brief note. Yes, to know the risk factors, to assess whether the pregnant woman is really having some pre-existing disease, or in her present ANC is she going to develop, or any new complications are there, and then in labor. And if for all these things, okay, pre-existing in pregnancy or in labor, are they modifiable or non-modifiable? So we know some things we can treat, like for example hypothyroid, hypertension, GDM, these things are treatable, isn't it? So let us say a major congenital anomaly like Eisenberg's and all cannot be treated at that age, but definitely others can be treated. So modifiable ones we treat so that the pregnancy and the delivery happens smooth for the patient, isn't it? So now coming to the antenatal visits. So these antenatal visits initially for a longer time, okay, it was 4 antenatal visits, still almost 2016-17 we considered as minimum number of 4 antenatal visits. But remember, it is changed now. From 2016 it is minimum antenatal visits are 8. These are not ideal. So ideal is every month she has to come till 28 weeks, then till 36 every 15 days she will come, after 36 she'll come weekly. So this is the ideal number of ANC visits. But as per the 2016 WHO, minimum ANCs required are 8. Okay, the minimum visits are required are 8. There is no more doubt or question on this. Okay, the minimum ANCs are 8. It is not 4. For a long time we have followed 4, but now it is changed. It is not 4. Okay, the minimum ANCs are 8. And I'm sure this time they will not ask you a direct question saying what is the minimum number of ANCs. It is not like that. Okay, so the minimum number of ANCs would not be the question. They'll ask you what are the ideal visits, minimum visits. So ideal, I've already told you, it is monthly one, and then it is weekly, 15 days from 28 weeks to 36 weeks, and weekly ones from 36 weeks. So minimum visits are these. First trimester at 12 weeks. So remember, for NT scan she has to come first, that is between 11 to 14 weeks. So ideally by 12 weeks she has to come. That should be her one visit in first trimester. Then is for anomaly scan. So anomaly scan we do between 18 to 22 weeks. So this anomaly scan would be her next visit. After that, every 4 weekly, that is at 4 weeks, that is 24 weeks. Then comes the third trimester, that is at 30 weeks. Okay, so 30 weeks she'll have 2 visits 4 weeks apart, that is at 30 weeks and 34 weeks. Then every 2 weekly she will come. One is at 36, 38 and 40. So these are the ideal visits, I'm sure. Or maybe in recent soon this question will be there, maybe a history why she visited these number of visits. Is this the minimum ANC as per the WHO module? No. So remember, it is 12. One is NT scan, anomaly scan. So most important things, these two are easy to remember. Then after that, 4 weeks later later in the second trimester, that is at 24 weeks. And in third trimester, she will have at 30 weeks is the first one. Then 4 weeks later, that is 34 weeks. Two visits are 4 weeks apart. Then every 2 weeks, that is 6 and 38 and 40. So these are the minimum number of ANCs that she should have. Okay. So coming next, okay, so now you've understood all these things. Let us go ahead with the diagnosis of pregnancy. So now coming to the diagnosis of pregnancy, we have seen in last 2 years itself, there were three questions, two times in NICT and one time in NEET PG. It was such a recurrent question. What are presumptive signs, probable signs, positive signs, and practical way? So let us see what was the question. In our NEET PG 2025, this question was there. A patient who hasn't had a period for last 2 months, okay, has an enlarged uterus on examination. So this is on examination finding. Other findings including prominent Montgomery glands, darkening of the areola, bluish tint on the vaginal tissue, and dark line on the abdomen, that is your linea nigra. So all these are what? These are signs of pregnancy, isn't it? So these are signs of pregnancy. So next, coming to the answer. What are the answers for this they had given? Signs of pseudo pregnancy? No, it is not a pseudo. We have seen so many positive signs, isn't it? Then probable signs or presumptive signs. This is what you are getting confused with. I'm sure of that. So presumptive means what patient thinks. Okay, she's thinking presumptive. So whatever patient complains or like let us say amenorrhea, increased frequency of micturition, early morning sickness, unable to eat, loss of appetite, all these things are presumptive signs. What patient presents. Okay, symptomatic ones. Symptoms are your presumptive signs, whereas probable signs are what you examine. Let us say uterine size, bluish tint, or the different signs on examination that I'm going to tell you soon. I'm sure that description also will be there, or a photo will be there, or video may be there this time. So that is why you should know all these things. Okay, so the correct answer here is what? What is the correct answer? So you can message in the chat box also, friends, that whatever you think is the correct answer, or if you get any doubts also, you can measure assess, I mean ask in the chat box. Just a second, I'll see the chat box if there is any questions in that. So you can raise your hand, or even you can check, or you can tell what questions you have. You can message in the chat box. Maybe immediately I would not clear. Once the session is over, I'm sure I will clear all the doubts so that the flow is there. When you see recall video of the same video, you will have good source of information without any break. That is why we'll clear after every topic. We'll clear if you have any doubts. Okay. So next, coming to the diagnosis of pregnancy, as we told, presumptive signs are what? These are the patient symptoms. So patient symptoms like amenorrhea, breast changes, morning sickness, all these things we told, isn't it? Patient is appreciating fetal movements, quickening, skin pigmentation, linea nigra, she's complaining, or increased frequency of micturition, easy fatigability, salivation, pica, or irritable temper. All these things are patient symptoms. Coming to the probable signs. So enlarged abdomen, you can feel the uterus. Let us say uterine size is increased. Okay, with Hagar sign. What is Hagar sign? On bimanual examination, isthmus between the uterus. Okay, isthmus and between the uterus. The cervix is soft and compressible. Let us say this is the uterus. So when you put here, this cervix will be soft and compressible. There will be mass here because fetus is inside here, isn't it? So this part will be soft and compressible. This is your Hagar sign. Goodell sign, as we have seen in the examination that they have told also, soft cervix. Okay, begins at the external os and goes upwards. The cervix becomes soft because of the progesterone. Then Braxton Hicks, this is contractions. These are seen after 4 months. Once the placental development is there, that is when we see this. So this is seen after 4 months. And external ballotment, that is you can appreciate movement, baby move the baby inside. So what is that? Internal ballotment is seen early, whereas external ballotment is seen late. So when you do a external ballotment, that means when you push the baby from here, the baby comes and hits your other hand. When you push the baby from this side, the baby comes and hits to your other hand. Why? There is increased amount of liquor, isn't it? So much liquor is there, baby is floating inside. So when you push one hand, it will hit the other hand. When you push from the other hand, it will hit the other hand. What is internal ballotment? When you are doing a PV examination, you just move the fetus, so it will move up and hit back. So that is internal ballotment. Okay. So other probable signs are your Osiander sign. You can remember like oscillations. Osiander is your oscillations. I think there is a slight delay in screen movement, right? So maybe some network issue. Yes, we are back. Okay. So this Osiander sign you can remember as a oscillation. So this oscillation is nothing but like pulsatile. When you do a PV in the fornix, because of increased blood flow, what will happen? You can feel the increased pulsation. Pulsation in the lateral fornix starts from around 8 weeks. Okay. Then Piscacchi sign, here you can see the asymmetrical and lateral. So let us say this is the uterus. Uterus is not initially enlarged uniformly. Why? Because this side alone the embryo is attached. So this side will be increased in size. So this asymmetrical enlargement is called as Piscacchi sign. So then coming your Palmas sign. So what is Palmas sign? Rhythmic regular contractions are there. So here when you do a PV examination, you can feel the contraction. Okay, since the uterus is very small, only between 4 to 8 weeks you can appreciate this. So that time, since the uterus is very small, when you do a PV, you can feel this contraction. For every 30 seconds there may be one contraction. For every 10, initially it will be more frequent. As it goes faster, it will increase in after 30 seconds, 1 minute. So we don't do PV for 1 minute, so we don't appreciate this. Initially these contractions are there every 10 seconds. So that time you can appreciate these contractions. This is your PAMAS sign. Okay, and uterine shuffle also you can hear. Then coming to the definitive signs. So recent questions were in presumptives and probable. Maybe this time they will give you a definitive sign. So what are the definitive signs or positive signs? These are your fetal parts. When you check, you can see the fetal head. You can feel the fetal limbs. You can feel the fetal back. So this becomes your definitive sign. Fetal movements felt or by examiner, listening to the fetal heart sounds or the shuffle uterine shuffle, and then x-ray. So we don't do x-ray, but by in case unknowingly somebody has done annular shadow of the skull, vertebra, spine, curved parallel ribs, and you can see the shadow of the limbs. Okay, so all the bones that can be seen, isn't it? So that becomes very evident that she's pregnant. But remember, that is not done right now. We do not do x-ray. Whenever we do x-ray, that is why we should always ask the LMP of the patient, make sure she's not pregnant before doing any x-ray exposures. Next, coming to scan. This is also again a definitive sign, isn't it? You can do TAs by around 6 weeks and TVS by around 5 weeks. So earliest you can do is TVS, as in that fetal pole, heart rate, and embryonic movements, and Doppler fetal heart rate you can start checking by 10 weeks. So remember this, with Doppler you can assess the fetal heart rate as early as by abdomen, the uterine Doppler that you have no in the scan, that you can assess the fetal heart rate as early as 10 weeks. Okay. So lastly, coming in ANC per se, without any other delay, let us conclude this ANC part. So this ANC part has what now left is immunization. So in pregnancy, immunization is equally important, isn't it? So why is immunization important? Because recently we have a change. So not recent, it's been old now, almost like 6, 7, 8 years. Initially, what we used to give TT. So in your exam, they can ask you TT. What is the recommended dose vaccine right now? It is TD, correct, right? What we are using right now is TD. I don't know, again, there is a delay in the screen. Please reply in the group. Can anybody see the screen moving? Immunization in pregnancy has come up, as I cannot see. From the technical team, anybody? Sorry for the technical glitch, students. I am really very sorry. I wasted 5 minutes of yours. I hope now further it doesn't happen. It was solved. And let us see now the immunization. Okay, so what is the immunization? Previously, what we used to give was TT, isn't it? So right now, what we are using is TD. So TT was pretty old. Now we do not use it anymore. Sorry, this TT is no more used. And the same dosage, 0.5 ml, IM, and it is to the deltoid. All these things are same, but it is TD now. And when do we give it? You should not say regular for everybody. Let me give you an example. Now they give you a question. Okay, a pregnant lady walks to you. She is let us say 8 weeks pregnant now. Okay, and she asks you, she has delivered a child who is right now 2 years old, and she has come for TT injection. So she'll ask you how many doses of TT should she take. Okay, this is her first question. What is your answer? So all of you know TD. Everybody know. I'm very sure of that. So TD you have to give right now, and she is delivered a child. She is gravida 2, para 1, living 1, and she is 8 weeks, and the first child living is 2 years old. Okay, what is her minimum dosage of TT that she should receive? Is the question. Yes, please answer me. What is the minimum dosage? Is it one dose or two dose? Is the question. I think you've yet to join back. Okay, let me tell you the TD dosage is if it is less than 3 years, the previous delivery. If she is okay, let me clear the screen once. Till then, I'll give you the time to answer. Sorry. So she is gravida 2, para 1, living 1, 8 weeks pregnant, and she's having a live child. That L1 is 2 years old. So she's asking you how many doses of TT should she take? Okay, this is her question. So what would you answer? Yes, the correct answer is one dose. Yes, I have got three, four correct answers. Very good. Um, Mohammed, Suresh, and Aisha, all of you, very good, excellent. It is one dose. Why? For a person who is with less than 3 years of her last dose, let us say in her last pregnancy, she has taken the booster, which is less than 3 years, then we give only one dose. Okay, so this is the what very important thing right now. Okay, and then coming to the hepatitis B, immunoglobulin can be given in pregnancy, okay, but the vaccination can be given before pregnancy, not in pregnancy. Anti-rabies vaccine, hepatitis A vaccine can be given. No live vaccines can be given, and also yellow fever, which is not in India per se, but it can be given if it is comes in your question. Okay, so this is the basic things that you should know. Okay, the one is TD. Okay, TD is given, but the dose is all remaining the same. TD is 0.5 ml, deltoid, IM, everything is same, except it is given initially in the first trimester whenever she comes, and then 4 weeks later you will give. But if she is taken within last 3 years, you will give in the next pregnancy. It is only TD booster. You will only give TD booster. You will not give a full course. So that is why it is appropriate. Okay, these questions are likely expected because these are very important clinical scenarios. Okay, now next coming to the NEET PG 2021 question. Okay, now this question, a 30-year-old woman who has been taking oral contraceptives pills for the last 6 months presents with 6 weeks of amenorrhea. What is the most appropriate method to accurately determine her gestational age? Okay, tell me this much now. What should you do? Why is this? I'm really so sorry for this technical issues. I don't know why this is happening, but yeah, but this is happening. I am going very fast. Or screen is going very slow. I'm not understanding. I'm really so sorry for this technical issues. I don't know why this is happening, but okay, we are good to go. I heard from the technical team we are good to go. Sorry. Sorry for all the delay, and we are good to go. Let us see now a 30-year-old woman who has been taking oral contraceptive pills for last 6 months presents with 6 weeks of amenorrhea. Okay, what is the most appropriate method to accurately determine her gestational age? Yes, tell me. What is the correct answer here? Okay, she was on oral contraceptive pills, okay, for last 6 months. How will you determine her expected date of delivery? So, will you do the Neglis formula? Will you use the scan or will you use the examination findings? What would you use? Yes, tell me the answer. Yes, the correct answer. Yes, I have already got two, three correct answers. Yes, Suresh has given and Tarun has given me a correct answers. Yes, the correct answer is crown rump length. Why is it the crown rump length that we are using? Why not we are using the LMP by LMP? Because she was on OC pills. So that is why we are not sure her exact LMP. And when we say excellent dates, we should have her regular cycles without the usage of LMP pills, isn't it? Without the usage of OC pills, isn't it? So that is why we use here the crown length or ultrasound, early pregnancy scan ultrasound. So coming to the crown rump length. So last time they've asked you like this. Now they can ask you, when do you assess the crown rump length? At what period of gestation, or what should be the crown rump length to take this as the EDD? So crown rump length between to 45 to 84 mm. Okay, between this. For example, now in this exam, they can give you a question. Okay, you have done a scan for a patient. Her crown rump length is, let us say, 90 mm. So, will you use crown rump length this time to assess her gestational age? No, after 84 mm, it is head circumference, which is you should use for the assessment. Okay, so between 45 to 84 mm of crown rump length is what you should use the crown rump length for measuring the expected date or gestational, exact gestational age. Anyways, they had given you accurate determination, since we cannot use the fundal height or any other things. So coming to the last option, adding 256 days to the last menstrual period. So in this, how do we do get this last menstrual period? For when do we add 280 days or 256 days? Ideally, for every woman, we add 280 days, isn't it? Where do we get this 256 days? If they had given you an embryo transfer date, okay, it was an IVF conception and it was an embryo transfer date that they had mentioned, at that time you will use this, adding 256 days, okay, because the first, say, 14 days were not there, isn't it? So that is why here you will add 256 days. Okay, so this is the basic understanding of this question. Coming to the next question, yes, let us continue here. You tell me the answer for this. Okay, a 28-year-old woman who presents for a routine antenatal visit in her second trimester. 4 years ago, she delivered a healthy full-term twins. What is her current obstetric score? So we have always had such a basic question to high-level questions. So you will tell me what is the correct answer in this? Yes. A 28-year-old woman is there who is pregnant right now and she has had twins previously. Okay, what is a gravida and para? So how many times has she got pregnant? Yes, she has got pregnant twice. That is once now and 4 years ago. So 1 and 2. So she has got pregnant twice. That means gravida is 2. How many times has she delivered? Though she has delivered twins, she has delivered once only. At that time, she delivered twins, isn't it? So it becomes para 1 or 2. Yes, it becomes para 1. Very good. So the correct answer here is D. Gravida 2, para 1. What would be the living? Living would be 2. Para 1, living 2. Para 1, living 3. This means they are twins or triplets like that. Correct, isn't it? So the correct answer here is D. Okay. Physiological changes. So next we are going ahead with the physiological changes. So what are the physiological changes in pregnancy? It is equally important, isn't it? So physiological changes means how the uterus changes, how the other organs changes. The important part is first is uterus, definitely it is going to vary in size. So firstly it is 7.5 centimeters in length, which almost increases to 35 centimeters in length. Okay, so the change is so high, the huge. Okay, so their change, which was initially small in size, itnusatha uterus, which is not even palpable otherwise in a small young person, or it is in what you say, otherwise we do not even feel it unless until we do PV examination, becomes as huge till the xiphisternum, isn't it? So it almost increases by 35 centimeters, which usually was a 50 grams in weight, becomes almost 1 kg, 900 grams to 1000 grams, almost becomes 1 kg, which had initially capacity is very less, almost it increases, its capacity increases by 500 to 1000 times. Okay, these values I think they may ask, so I've given you these values. Other than uterus, what other organs have undergone major changes, like organ, I mean increase in size? What are the other organs which increase in size? One is uterus, breast increases in size, then is your what you say, pituitary. Okay, pituitary also increases in enormously in size, almost 100 times it also increases. That is why pituitary hematomas, hemorrhage following postpartum hemorrhage, pituitary necrosis are now very common. Okay, that is not very common, I'm sorry for that, it is not very common. That is why it is happening, not for other organs but this organ. Okay, pituitary, Sheehan syndrome, that is called as Sheehan syndrome. This also they have asked you multiple times question. Okay, the most increasing in size organs are your breast, uterus, and pituitary gland. Other than this, your vasculogenesis, I mean what you say, hyperplasia. Hyperplasia is seen in vascular neovasculogenesis is also very common. These things you should know for sure. Okay, next coming to the respiratory changes, a multiple times asked question. So respiratory changes, what are the important? So you can see all these things. So you can see what is the normal tidal volume, it is 450. In pregnancy it increases to 600. The most important thing that you should know in this case is the tidal volume. So tidal volume is one which is going to increase enormously, or it is almost increasing by 30-40%. Let me tell you, tidal volume is here, it increases by 40%. Okay, so this 40% is really important. Why? Because tidal volume is increasing, the minute volume also will increase. So minute volume also increases. So the important things that you should know, I have tabulated for you. You can take a screenshot of this and keep for your quick revision during your exams. Correct, isn't it? So during your exams, you should be very calm and cool. So you should just revise the important points. What are the factors that increases in respiratory system? Is tidal volume, minute ventilation, and respiratory rate. Though respiratory rate is not increased enormously, especially nearing the term it increases, not in the initial antenatal period. When the uterine size becomes increasing, pushing the diaphragm is there, that time there is increase in the respiratory rate, and it is not very significant. But the tidal volume in the minute, because tidal volume is increasing, the minute ventilation also increases. Next comes your factors which reduces, that is your residual capacity, residual volume, chest wall compliance. That these are the factors which reduces, and lung compliance remains the same. This much you should know. Okay, so next coming to the vascular changes. Yes, as we know, in vascular changes, again the same thing. So as we know, in vascular changes, the systemic vasodilatation, okay, peripheral vasodilation or systemic vasodilation is a must know. Okay, it is must know. Here it is most important in hypertension also. Why? Systemic vasodilation is normal physiology. It should happen. When it is not happening, it is abnormal, isn't it? So systemic vasodilation will lead to what? High flow, whereas low resistance. Okay, but in hypertension, what will happen? In hypertension, it will become low flow and high resistance. Okay, this is also multiple times asked question. So it will become low flow and high resistance in case of hypertension. So that is why you should know in normal pregnancy it should be high flow. When is the high flow? Just imagine a pipe. Okay, when there is no resistance at all in a pipe, there is easy amount of fluid or more amount of water that is flowing, isn't it? So that is why dilatation is there. But let us imagine a pipe which has lot of constriction. So that time you'll need lot of pressure also. The resistance also is there, flow is also reduced. So there is increased resistance and reduced flow. So this is how you should imagine. You should not try to by heart anything, especially in OBG. It is very easy and nice subject. So this will lead to lowering of the BP. Normally in pregnancy, BP lowers. It should not raise. Correct? No. Increased aldosterone. Why? There is increased fluid volume. There is plasma volume increasing, blood volume increasing, volume expansion and increased aldosterone is there, which is physiological in pregnancy. Also, there is increase in glomerular filtration rate and also increase in renal blood flow. Okay, so these may be your easy gaining marks question. So easy to remember. Angiogenesis. Yes, so many new increase in size, new vessels so should come up, isn't it? So next coming to progesterone, which has the major key role for all these changes. So this progesterone is very important for us. That is stimulates nitric oxide synthesis. So here it leads to increased systemic vasodilation, which causes the lowering of BP. Okay, and also it stimulates aldosterone secretion. It helps in increasing volume expansion, increasing glomerular filtration rate, and renal blood flow. So all that we read is mostly due to the progesterone. So as we know, any hormone that in pregnancy is the most important, P for pregnancy, P for progesterone. Yes, so progesterone, if you do not know an answer or anything such sort also, progesterone is the key for almost everything. Okay, you can take a guess, but since you have negative mark, always think an answer in your exam. Okay, decreased response to angiotensin. Okay, angiotensin is what? Is a vasoconstrictor. So we do not want a good response to that. So we do not help angiotensin to act. So we decrease its activity. So angiotensin ACE is there. That means which will lyse the angiotensin. So angiotensin activity is not increased in pregnancy. You should remember this. So and this is how the AC inhibitors also act. So do we give AC inhibitors for hypertension in pregnancy? Yes, tell me. I'm waiting for some response. Do we give AC inhibitors in pregnancy? Yes, very good. We do not give AC inhibitors in pregnancy. They are teratogenic and we do not prescribe for anybody. It is a complete no. It is contraindicated. They are teratogenic. They affect on the fetal liver and kidneys. So we do not give. They are teratogenic. Okay, very good. Very good, Shruti, and also Mohammed, and many people have given a no answer. Very good, you've studied very well. I hope this confidence continues in your exam and you'll answer really well. So remember, in exam, it is not about knowing everything. Okay, the day before exam, it is not about that. It is how you assess yourself, how you have learned over a period of time. All these things with your revision, I'm sure you will crack in your exams. Okay. So next coming to this. So this chart tells me the cardiac output. This is also frequently asked question. When is the cardiac output maximum? Yes, tell me when is the cardiac output. I know you have already seen the chart, but still, let me take a guess when is the cardiac output maximum. Now you cannot tell. Okay, maybe. When is the cardiac output maximum? So this is the chart I have given. When is it in purple color? When is it in peach? And these two are almost same. And this is a next. Okay, this is one, two, this through are three, and this is the fourth one. Okay, tell me. Which period is one? Very good. Yes. Am I giving too much gap? Okay, yes, students are getting back to me. Yes. Mohammed. Yes, you are slightly correct, but it is not correct. You can think one more time and you can change your answer, given another answer for sure. Again, Shruti or Aish is giving me the same answer. Please think one more time, dear. It is slightly changed. When we're stressing so much, it not be maximum in the third trimester. And if it is in third trimester, you can tell me the gestation also. Okay, fine. Let us get back to the question. Okay, the maximum cardiac output. Your answering wrong is also equally important. Why I'll tell you. So when you answer wrong, when we correct it, that will be in your mind for a longer time, and you will not forget it. Okay, when you in even in class, try and answer something. Even the teacher is happy that you're listening, and also you will also remember. Oh, that day I answered wrong. That is not the correct answer. This is the correct answer. You will know. So yes. So it is immediately after delivery. Yes. Tamilmati. Yes, you have given me the correct answer. Definitely, you will reserve a like for this. Yes. So, immediately after delivery is when the cardiac output is maximum. Immediate postpartum. Within immediately, like let us say 15 minutes or half an hour immediately after delivery, the cardiac output is maximum. Why? The afterload, so much of blood which was in the uterus, everything is going back to the heart now, isn't it? So, initially during pregnancy, it was increasing, the afterload was not much. Now everything is going back. The fetus is delivered. All the blood that was in the uterus is squeezing. Everything is going back to the heart. So the afterload is increased. So it enormously increases immediately after delivery. Then coming into the labor. So in second stage of labor or in the last stage of labor is the next highest cardiac output. The first is immediately after delivery. Then is your second stage of labor and your active phase of labor and your third trimester, that is between 28 to 32 weeks in third trimester also. Okay, so these are the two periods where it is equal. These two are almost third place, and the initial, the latent labor or the early phase of labor becomes the fourth place. So all these first four you should know. Okay, when is it maximum and why is it maximum? Maybe now they may not ask you when is it maximum, they may ask you why is it maximum. They can give you a history and say this is the cardiac output of this patient immediately after delivery. Why is it maximum after delivery? Yes, this is where your core concept matters. This is where your knowledge matters. So immediately after delivery, it is maximum because the cardiac output or the input, the afterload on the the preload on the heart is so much because everything is coming back to the heart now. So the preload on the heart is so high. Okay, so the preload increases. So this preload increase will lead to what? Increase in blood volume going back to the uterus. The uterus is squeezing and sending everything back to the heart, causing it increase in the cardiac output. So remember, everybody who gave a third trimester, yes, it is immediately after delivery is when the cardiac output is maximum. So going ahead with the blood volume changes, they can give you this graph as simple as this graph. So what is red indicating? Red is your RBC volume. So your red blood cell count, will it increase or decrease in pregnancy? Yes, definitely it increases. Whereas your plasma volume also increases and blood volume also increases. Okay, blood volume, plasma, RBC, everything is increasing. Then what do you understand by physiological anemia? Why there is physiological anemia? Yes, this physiological anemia is because of this gap. You can see this gap here, right? Okay, this gap is causing the physiological anemia. So the blood volume increases more or the plasma volume increases almost 30-40%, whereas the blood RBCs will increase only by 15 to 20%. So this difference will cause physiological anemia. But remember what said and done. Never HB should fall less than 11 grams. Okay. And 10.5 in second trimester. So it should never fall less than 10, 11.5 in first and third trimester and 10.5 grams in your second and third is in your second trimester. Okay. In postpartum, what is the cutoff? 10 grams. Okay. Less than 10 grams is considered. Post delivery is this. In for So in first and third trimester, it is 11 grams. In second trimester, it is 10.5 grams. Immediately after labor postpartum, 10 grams is less than 10 grams is considered as anemia. Okay, so this is postpartum. So these values you should know. And what is physiological anemia? Physiological anemia never crosses this level. Okay, it is there some amount of, let us say previously her HB was 12. Now it has come back to 11. So, but it never goes below 11 or 10.5. Okay. When is the physiological hemodilution maximum? Okay. Tell me this question answer now. When is the physiological hemodilution maximum? Yes. Hemodilution is maximum. Which trimester now? Hemodilution. First trimester, second trimester, third trimester. Easy question. Now you tell me. There is hemodilution. Everybody understood, isn't it? RBC is not raising as equally as that of your plasma volume and your blood volume. Yes. Yes, Suresh gave the first answer correct. Suresh, you are correct. That is in second trimester. I'm sorry, Harini and Dr. Taran and Shruti, but pardon me if I'm taking your wrong names wrong. That is what I can read from your mail IDs. But still, you're good. But third trimester is not much. That is why we say in 10.5 is the cutoff in second trimester. So hemodilution is maximum in the second trimester. That is why we've reduced the HP level a little in second trimester. Okay. In general, if they give you a label under which value in pregnancy you consider as anemia, take 11. Okay, if they give you pregnancy specific, take 11 and 10.5. Okay, so second trimester is when there is maximum hemodilution. Okay. So before concluding the physiological changes, let us see this question which was previously asked multiple times. Maybe now there will be a repeat question. I'm not sure. This was not there for last 2-3 years, I'm sure, but it was there in last 5 years. I'm sure of that also. Okay. So which are the clotting factors which decreases? This was the question every time they had asked. So you should remember 11 and 13 are the factors which decreases. Again, it is a memory based question, less likely to be asked, but you should know. Okay. It is very important. 11 and 13 are the factors which decreases. 7, 8, 9 and 10 and 1 are the factors which increases. Okay, this much you should know. Okay, now is the question time. Yes, all of you, fasten your seat belts, start answering fast. Let me see as fast as I'm talking. I'm really sorry for my pace of language. I'm usually talking in a faster tone. That is why usually whenever I take a class, students say, ma'am, slow down, ma'am, slow down. But I'm trying to slow down. I hope you understand this. And this is a quick revision session, isn't it? You should be fast. You've already read all these things. You should be fast. Yes, answer me. What is the image that is shown in this figure? This is your very likely question in the upcoming examination. So what are you trying to see in this image? What is the image that is shown? Which period of gestation you ideally want to do? Which period you want to do this image? What is its importance? Yes, anything can be asked. Knowing the concept is important. Yes. Okay, Shruti has asked me why in second trimester there is maximum hero. See, the plasma volume increases that time maximum. The progesterones are so. Later gestation, the volume is already already increased, okay, and the anemia correction also is much better. So you have taken the iron tablets, everything. So in second trimester or late second trimester, let us take till 28 weeks or 30 weeks is the maximum hemodilution. Later to that it slightly reduces until 32 weeks it is there, but maximum hemodilution is happening at this period. So it is not about later also there is hemodilution, but the rate at which it raised, you remember the chart, the rate at which it raised, you can see in this chart, the rate at which it raised here is maximum, isn't it? The rate at which it is raising in the third trimester is not so. So that is why the hemodilution is maximum in the second trimester. Okay, you can see here. So the rate at which it is raising, the plateau, you can see the it is later it is plateauing. Here it is peaking. The spike is there. Correct? No? That is why. I hope I cleared your doubt. So now let us go back to the scan. Yes, the image says it is a NT scan. Yes, Dr. Taran, you're correct. But how could you write 18 to 22 weeks? When do we do it? What scan do we do between 18 to 22 weeks? This is an anomaly scan, or you can say it as TIFA scan, targeted fetal imaging, isn't it? So the correct answer here is NT, as I've got from many of your students. Yes, Aisha has given me again the correct answer. Which period? She gave the first, that is 11 to 13 plus 6. It was initially told, now the Williams says it is 14 weeks. There is no much difference. It is 11 to 14 weeks. Previously, when we were studying, they used to say it is 13 plus 6. Don't tell it as 14 weeks. Okay, so specific they were. Now the Williams, the Bible of Obstetrics itself is saying it is 11 to 14 weeks. Okay, so yes, correct. Now coming to the importance, yes, the one somebody has given me yes, holy, yeah, yes, correct. I'm really sorry for the other names, but yes, the importance is to screen for Downs or any chromosomal anomalies or the neural tube defects. Okay, so of all these things, yes, you have given Downs as the answer, correct it is, but majorly it is neural tube defects. Okay, you should answer it. No, all neural tube defects are not Downs, or there are many set of examples in that, isn't it? So as a gross, it is neural tube defect. If they've given specific, it is Down syndrome. What is the cutoff? More than 3 mm. Okay, if it is more than 3 mm, then it is the high. Then you should do what? Will you terminate? Okay, they've given you a scan. Let us say they've given an image where, okay, in this figure, where is the NT? Is this what I've marked the NT? The nasal tip, skin, and the nasal bone. Is this where we see NT? Where do we see NT? It is between the soft, this tissue and this tissue. Okay, so I'll just mark in a different color. So this is the NT measurement. Okay, this should be less than 3 mm. Okay, this is ideal. So this is the NT measurement. So here is where we measure. They can give you multiple figures and tell which is exactly measures, which is the correct figure which is measuring NT. Any sort of question they can give you. Okay, your concept is correct. Don't worry about the question, dear. Okay, it is really easy to answer the question when your concepts are correct. So this is where you measure the NT. It is the tissue between the subcutaneous plane and the spinal cord. So this fluid here, if there is excess fluid accumulation, that means there is some neural tube defect. So it should be less than 3 mm. Okay. So how do you see? Where you can see the nasal bone, nasal tip, third ventricle, fourth ventricle, everything in a single plane, where the head is not hyperflexed or hyperextended. It should be in a neutral position. In such image, you should take your NT image. Okay. So in a sagittal section, this is a sagittal plane. Okay, these are the important things. I think in radiology they would have taught you, but still I'm telling you, it is a sagittal plane where you see in a single image, you will see the nasal tip, nasal bone, third ventricle, fourth ventricle, and you can see a clear picture of this NT distance, the soft tissue and the spinal cord, this distance, and you should take this all in a single image. Everything, the nasal tip, bone, third ventricle, everything should be in a single image, and the fetus should not be hyperflexed or hyperextended. It should be in a semi-flexed position. It should not be fully flexed or fully extended. It should be semi-flexed position. Okay, this is the position we take the. Okay, so and again, anomaly scan is between TIFA scan. What is TIFA full form? Targeted imaging for fetal anomalies. It is done between 18 to 22 weeks. Okay. So I hope you have understood everything about NT. NT is a likely question or image-based question. Please have a look of this image later. Do you want me to clear the screen? So So I have cleared the screen. Please have a look of this image. It is really important for the present scenario of exams that you are having. Okay. Now, next coming to the biophysical profile, the BPP. So what is BPP? It is a measurement of the fetal well-being. Okay, there are two things. One is antenatal well-being of the fetus. In that we have two things. One is in the early gestation, where we do NT scan to see anomalies scan, or we do double markers, triple markers, quadruple markers, these things. This is early gestation. As the fetus progresses, let us take it has crossed the second trimester, it's reaching the third trimester. That time we don't do these scans. What we do the biophysical profile. So you should know. So early gestation, in early pregnancies, what we do in early pregnancy, we do for fetal well-being. What do? We do NT scan, anomaly scan, double marker, triple marker, NIPT, or your invasive methods like chorionic villus sampling or cordocentesis or amniocentesis. These are the early fetal well-being markers. Whereas biophysical profile is your later gestation, in third trimester, how to assess the fetal well-being. So if they can give you a scenario, let us take they have given you a scenario which says pregnant women, she has walked to you, she's right now in her 32 weeks period of gestation. Which of the following would you do for her for fetal well-being assessment? They have given you double markered NIPT, biophysical profile, or let us say it as growth scan. So of all these things, fetal well-being is specifically assessed in your biophysical profile. Growth scan in general assesses everything, but specific is by biophysical profile. Okay, let us say she has come with decreased fetal movements. So what do you assess? You will assess the biophysical profile in the Dopplers. Okay, decreased fetal movements. Okay, these are the important things. How you will assess, what investigation you should send to this patient. So these are the likely questions. How you diagnose is where your key exam is. Okay. So coming to the biophysical profile, what are the key parameters in this? This has 5 parameters. One is NST, that is the non-stress test. Then is fetal breathing movements. The second one, then is the gross body movements, how the full body is moving, and the fetal muscle tone. Let us take one flexion and extension. This is one fetal movement. Okay, gross body movement, and then fetal muscle tone and amniotic fluid. So this is full BPP. So you are in a very busy hospital which has almost 100 scans per day. Okay, so you cannot do, or you're in very hurry. Your patient is having full decreased fetal movements. You're in very hurry to terminate her. Let us take she is a later gestation, or she's having severe other comorbidities, hypertension, GDM, so many other comorbidities. You want to assess it fast, quick. You cannot. You do not have this. Almost takes almost 30 to 40 minutes. Observation for at least 30 minutes should be done until you get all these things. Not that 5 minutes I did the scan and then you will tell no movements are there. No, it should at least observe for 30 minutes. So when you don't have this 30 minutes, or there is some amount of hurry because of her BP or anything, what you can do is a modified BPP. So what is modified BPP includes? There are only two things in that. Yes, this you will tell me. What are the two important things in modified BPP? The answer is in the chart itself. In these 5 things, you will select 2 of the major important things. What are they? Yes. Yes, Madhusudan. Yes, doctor. Yes, cardiac output usually return to normal within 1 week to 10 days. Okay, with it will come back slowly. But the peak which was there, which will come back to normal within 1 day, or in the pregnancy values, it will come back by 1 to 2 days. Usually by 2 days, it will come back to pregnancy value, the cardiac output, whereas it will come back to pre-pregnancy by 10 days. Yes, you are correct. Somebody, Dr. Tarun again has asked me, what if the treatment, if the NT is more than 3? Yes, definitely you should ask this. Let us say they've given you case scenario where the NT measurement is more than 3 mm. What you should do? Should you terminate this pregnancy saying NT is abnormal? So what is the sensitivity of this? Okay, for you it is too much. Sensitivity with other all parameters, it is 95%, but only NT is only 80%. So there's 20% chance that it can still be a normal baby, isn't it? So next you should go for other markers. So you can do a non-invasive tests like double markers, or you can do a NIPT. Double marker is ideally preferred in the early gestation. If she's later gestation, let us say she's come to late 16 weeks and so, you can do quadruple markers, but none of them are confirmatory. confirmatory. Okay, so confirmatory is only by invasive procedures. So invasive procedures you can do is chorionic villus sampling, you can do cordocentesis, or you can do amniocentesis. I'm going to tell you those things also in recent soon. But remember, this is not only the thing that you have to do. You have to do further investigation. If NT is more than 3 is not an indication for termination. This is what you should remember. They can give you patient is asking for termination, but this is not an indication for termination per se. Just the NT is high. Okay, you should make sure that there is anomaly. The confirmatory is only by invasive testing. Only confirmatory examination says it is abnormal, or there is Down syndrome, or the karyotyping said there is 21 chromosome triple is there, then only you can do the termination. Okay. Modified biophysical profile includes non-stress test and amniotic volume. Yes, amniotic fluid. So these are the only two things in the modified biophysical profile. Yes, this one and this one and this one. So modified biophysical profile, out of these things, which is most important is NST and AFI. So these two are the most important things that you should know. Okay, very good. Now coming to the biochemical and biophysical screening. As we told, that was in the later gestation. Now if the pregnancy, if they've given you an early gestation. So in early gestation, let us take, she is between 11 to 14 weeks. What all you can do? Combined test, that is your beta HCG, PAP A and NT screening. This is the best. If all these are done, you are 95% along with patient's age and the other clinical features you have taken. Okay, only these things without patient age, and this is 90% sensitivity. So in Downs, what happens? There is increase in beta HCG and reduce in PAP-A. You can remember as high. Okay, high. What is high? Which are the things which are high in Down syndrome? Okay, what is H? H for beta HCG and I for inhibin A. So these are the two things which are raised. PAP-A will be reduced. Let us say they have given you a clinical case scenario saying PAP-A is raised. What is your diagnosis? Will you write it as Down syndrome? No. PAP-A is raised mostly in preeclampsia cases. Or sorry, it is not raised in case of preeclampsia or Down syndrome. It is beta HCG which is going to be raised, and it is inhibin A that is going to be raised. Okay, you can see here. Beta HCG and inhibin A is the one which is going to be raised in case of Down syndrome. Okay, so this is what you should remember, and what parameters are tested in what gestation. This is also what you should remember. Okay, let me clear this one more time. Yes. So now between 11 to 14 weeks a patient comes to you, that time you will do double marker. That is your beta HCG and PAP-A. These are the markers that you will do. Very good. I hope we are connected back again. Yes, here what we are going to do is double marker and beta HCG. That is, sorry, PAP-A, double marker, and sorry, in 11 to 14 weeks, what we are going to do is a double marker, that is your beta HCG and PAP-A. In 15 to 20 weeks, what we are going to do is a quadruple marker, that is your maternal serum alpha fetoprotein, unconjugated estriol, HCG and inhibin. So the factors which are raising are, you can remember as high, HI, and they are high also, HIGH, high also. So that means it is HCG and inhibin A. Okay, remember it is inhibin A. Okay, in exam there was a question saying as inhibin B. I think I've added that question also. Okay, so coming to soft tissue markers, nuchal translucency and nasal bone. When do we do? Between 11 to 14 weeks. Nuchal thickness or NT, if it is more than 3 mm or nasal bone is absent, then you should think in terms of Downs, Turner's and other neural tube defects. Okay, then coming to cell-free fetal DNA. Is cell-free fetal DNA or what type of investigation? What is the name? Non-invasive prenatal testing. Okay, so NIPT is a full form is non-invasive prenatal testing. Okay, I'll come back to red. So here it is done after 10 weeks period of gestation. What do? We collect maternal blood. So in this maternal blood, we will get the fetal chromosome. These fetal chromosomes are assessed for any abnormality. So this almost has 99.9% sensitivity or even 100% for only Down syndrome. Rest all syndromes it cannot assess 100%. Only for Downs it has almost proven approval. Okay. So rest all it is not so. So that is why if there is any chromosome anomaly you are suspecting, you should always go for invasive method. But if the selfie fetal DNA, why do we prefer more than an invasive method? Because it is non-invasive, as it is non-invasive prenatal testing. Correct. Okay, so I hope you have understood now what are the markers, which gestation we do, and what is the thing which raises. Okay, this is also very important. Okay, for how will you counsel your patient further. So detection rate also I've given you just below it. Okay, now you will tell me what is the procedure that is shown in figure 1. This is figure 1 and this is figure 2. Yes. Waiting for your replies. I think there is a delay of almost 15-20 seconds of what I am going and what it is showing YouTube. Yes, very good. Madhusudan gave me the first answer. That is the chorionic villus sampling. One is via transabdominal method, one is via transcervical method. So, since the image-based questions are frequently asked now, I'm showing you this. You can see in this image, right? This image says here there is the chorionic villus. Okay, this is the placenta. So, transabdominally, we are trying to take the tissue. Okay, and here transcervically we are trying to take the tissue. So when we can do transabdominally, when the placenta is anterior. When the placenta is posterior or little lower side, we cannot do transabdominal. That time we'll go transcervical. Okay, so this is chorionic villus sampling, CVS. Okay, this is one of the invasive methods for getting the fetal chromosome or testing for the fetal tissue. Okay. Okay, next, who will tell me this answer? Oh, I'm sorry, Shruti and um, okay. So now your answer may be correct, Shruti, and this one. Yes, what is this? Suresh, how did you say it as chordosynthesis? I will show you chordosynthesis image also. Since I'm expecting these image-based questions, I've given you these questions to you. Okay. I hope these comes in your exam and you'll recollect and you'll answer in your exams. Yes, now Shruti, you are correct. This is amniocentesis. So your needle right now is in the amniotic fluid, isn't it? So you should see where your needle tip is. If it is in the placenta, it becomes chorionic villus sampling. So you're taking the villus tissue, okay, placental tissue. If it is in the amniotic fluid, as in this image, that means it is amniocentesis. Correct. Now you are correct. Okay. Then this image. Here, who's that? Suresh will answer me. What is this image? Yes. Yes, Suresh, you should answer for this question now. Yes, Madhusudan. Now you're correct, Suresh. Yes, very good. This is chordosynthesis. Now there is the needle is in the umbilical cord. Now you're collecting the fetal blood. So this becomes the chordosynthesis. So now you know what is chorionic villus sampling, what is amniocentesis, what is chordosynthesis. Now let us see what is this chorionic villus sampling, amniocentesis, and chordosynthesis. When do we do? First we do is chorionic villus. I have showed in the same order, so you'll remember well. So first or early gestation, what we can do from 10 to 13 weeks is CVS, then from 15 weeks is amniocentesis, and 18 to 20 weeks and later to that you can do is your chordosynthesis. So amniotic fluid usually starts by 16 weeks, 15, 16 weeks. So that is when we start. So you can do amniocentesis even till later days term also. Same way with the chordosynthesis also. Okay. So here is this is what is the most important thing. Here we'll take the trophoblastic tissues or the placental tissue which will have the fetal cells. Here amniocentesis. Here we'll take the fetal fibroblast, the fetal tissue which has got excreted and which is there in the amniotic fluid. Okay. Fluid for biochemical study also can be done. Where do we do fluid for biochemical study? In this, what can we do? RH negative. Previously, we used to do odds ratio when the Dopplers were not so good. Okay, so odds ratio, I don't know if you guys know or no. Right now, we have middle cerebral artery Doppler, which is very important. For RH negative, what we do? Middle cerebral artery Doppler. Since these topics I have not covered, I'm trying to add these important words to you so that you will remember. So, middle cerebral artery Doppler is very important. If middle cerebral artery Doppler PSV is more than 1.5 multiples of median. Okay, peak systolic volume is more than 1.5 multiples of median. That means there is anemia. You should either do intrauterine transfusion or you should do delivery as early and do exchange transfusion later. Okay, so either you can do intrauterine transfusion or you can do exchange transfusion. So this is about Rh negative. So here we can do the biochemical study also in amniocentesis. Whereas in chordosynthesis, what we get, we'll directly get the fetal blood cells, isn't it? Fetal white blood cells and RBCs will be got. And infections, here you can test for fetal infections and other biochemical study. What you can do in blood test, everything you can do, isn't it? So everything you can do here. So the amount of loss is almost the same in everything, little higher in the chordosynthesis. 0.2% and the other 2 1. Here chordosynthesis is a little like 1 to 2%. Okay, but it is in a good center, it's almost the same for everything. So now you'll answer me this question. NEET PG 2024 question. Yes. Unmarried woman, young, reports to the abdominal pain, has missed her periods. Pelvic examination reveals softening of the cervix. What is the name of the finding? Yes, this we already learned in the class right now itself. So I'm going ahead since we are getting late for the class. It's already become 6:30. So the correct answer here is Goodell sign. I'm sure you all would have answered this. Okay, this also I told you in the class. Which of the all of the following are routinely included in the quadruple marker screening? Except yes. I had told in the class. Let me see how many of you were attentive and you'll answer this question. Yes, first. Aisha and Madhusudan are very good. Correct answers. Suresh also very good. Correct answer. So many of you are giving correct answer. I think all of you will top this time in exams. Actually, the previous question and this question, both the answers are the same. I don't know whether you're answering the first question or you're answering the second question. Yeah, since Madhusudan has given two answers, I'm sure Madhusudan and Aisha gave me the two answers. Shruti also has given me one answer. Okay, so the correct answer, this is also inhibin B. I told you inhibin A is what we do. And which are the two things which will raise? Inhibin and HCG. So you can remember as high. This is all I've told you. So let us quickly now go ahead with our important topic, that is our hypertension. Correct. Yes. So hypertensive disorders, recently we have a lot of changes. We have got Gestosis score and many other things. So remember, the recent changes is not going to change your exam anyway. Okay. So you don't have to break your heads. Oh my God, so many changes have come. So it is very simple changes. But say, you know what is the definition of gestational hypertension? Yes, you knew. It is after 20 weeks of gestation, but there is no proteinuria or any other damage to the body. It is just only hypertension. Nothing else is happening. But previously we learned it as BP should return back to normal within 12 weeks. Correct? No? So we learned it as 12 weeks. But here it is 6 weeks. Now the recent change is 6 weeks. This is the only change right now. Okay, so don't worry, there is no much changes. Okay, and next coming to preeclampsia. So preeclampsia, we already knew the definition. What is it? And previously we used to call pregnancy induced hypertension PIH. Now it is HDP, hypertensive disorders of pregnancy. Okay, this is almost changed for so many years now. So this is what you should know. So in preeclampsia per se, it is after 20 weeks, it is proteinuria. What is the quantity of proteinuria? Still the same. It is more than 300 milligram in 24 hours or 0.3 in your urine dipstick or more than 1 plus. Okay. What is protein creatinine ratio? Urine protein creatinine ratio should be more than 0.3. Okay. Now coming to the other damages. If they have any other features, let us say like headache, visual disturbances, platelet low, deranged LFT, deranged RFT, any patient with all these things with high BP will come under preeclampsia. Okay. This usually resolves after delivery. Here also it should resolve within 6 weeks. Eclampsia. What is it? Preeclampsia with seizures is eclampsia. I'm very sure you've all learned this all thing. And chronic hypertension. So previously we are told after 12 weeks if somebody is persistently having BP or first trimester somebody has been diagnosed as hypertension, we call it as chronic hypertension. So now we have reduced again it to 6 weeks. So usually following a gestational hypertension or preeclampsia, pregnancy hypertension should reduce back within 6 weeks. Previously, it was 12 weeks. Okay, this much change, if you remember, it is more than enough. There is no much difference that you have to break your head. Okay, so coming to the gestosis score, now I'm expecting they can give you a history and tell you, ask you what is the gestosis. Since it is developed in India by ourselves, our studies, our Foxy groups, the esteemed groups have given this. So this helps to what is gestosis score? It is a predictive value to get whether she'll get preeclampsia or no. It is a predictive score, isn't it? A score of more than what is considered as predictive positive for preeclampsia. How much more than what should be the gestosis score to say it as hypertension? She is likely to get preeclampsia. Yes, tell me. Gestosis score should be more than. I'm waiting for your replies. Yes, correct. Preeti Dew, you are very correct. You gave me the first answer now. Yes, the gestosis score more than 3 is considered as abnormal. Then you should think that she is likely to get a preeclampsia. So this values I do not know how you can remember, but at least major things. If the age is more than 35 or less than 19 years, and if there is anemia, obesity, primary gravida, easy to remember. All of them have a single one score. You can take a screenshot of this or paste it somewhere on your wall where you chronically see. And you can just see where is one, where is two. Okay. So these are the common things that you should. I think Shruti and Madhusudan by mistake typed 8. It is 3. Okay. Now, coming to gestosis score of more than 2. Okay, sorry, gestosis score which directly have score 2 if there is hypothyroidism, because hypothyroidism has direct correlation or increased chance of preeclampsia and GDM both. So that is why here the score is more. Family history of preeclampsia, gestational diabetes mellitus, obesity, multiple pregnancy, and hypertensive disorders during previous pregnancy. All of them give a score of 2. For example, if they have given you primary gravida, 36 years, and she is let us say known obesity of BMI 35. So tell me what is her gestosis score now? 36 years. Obesity with BMI 35 is her BMI. What is her gestosis score now? Yes. Yes, very good, Aisha. Yes, see, 35 is the cutoff. When 35 and more it is grade 2. Okay, primary 1, 36 years 1, and BMI more than 35 I've given, so it becomes 2. If I had given BMI of, let us say, 32, okay, BMI is 32, then this BMI score becomes 3. So that will become 3. be it 3 or 4, still it is high, still she requires preeclampsia treatment, isn't it? She should be started with what? Aspirin. Low dose aspirin should be started for her, and she should get how much? 150 milligram of low dose aspirin should be given. This is the treatment. Whenever we predict something, we want to prevent preeclampsia. Now, how do we prevent? We give aspirin. As simple as that, isn't it? Why Suresh gave me 2? Madhusudan, I hope you understood. When BMI is 35 and more, it is 2 for the score. When it is 30, more than 30 to 34.5, then 9, it is 1 score. Okay. Suresh forgot the obesity score itself. Yes, see here, it is the primary gravida. Okay, you got it? So these are the common things they may ask you. They won't ask you severe things, but these are the common things they will ask you. I'm sure you should remember all these things. Okay. So chronic hypertension patient, she's already hypertensive, then she has more chance of turning into preeclampsia, isn't it? So it becomes 3. So pre-gestational diabetes or overt diabetes is there, then becomes 3. Very high chance of having preeclampsia. So diabetes, hypothyroidism and go hand in hand. Diabetes and hypertension go hand in hand. So all of one person gets one disease, very likely that she'll add upon many other diseases also. Okay. Okay. Now coming to the investigations. So urine protein should be done, and this proteinuria key diagnostic sign, that is 300 milligram. This you should definitely remember. In 24 hours urine should be there, and this is the gold standard. 24-hour urine of more than 300 milligram, but we cannot wait for 24 hours. Then we'll do urine dipstick. Urine dipstick should be more than or equal to +1. So, sorry. Then coming to the protein creatinine ratio, urine protein creatinine ratio more than 0.3. Okay, all of them are equally important. So why to monitor platelets, liver enzymes, and other important is important in you other sorry. Okay. What? Yeah. Okay, let us continue. Why is monitoring platelet count and liver enzymes as important as urine examination for proteinuria in preeclampsia? Why? Because we know end organ damage is one of the diagnoses. Not every patient should have proteinuria. For example, they can give you BP of 150 by 94 with low platelets, deranged liver enzymes, RFT is deranged, creatinine is very high. So anything they can give you. All those things will come under preeclampsia, isn't it? They are not gestational hypertension. So here you can see what are the investigations we should do to rule out all these things. Yes. First is serum creatinine. If it is more than 1 in pregnancy, renal involvement is there. Platelet is less than 1 lakh, or there is LFT deranged. When do you say it as LFT deranged? It should be double, more than double. That means normal is less than 35 values are there in for is AFT, you know. So these things, if it is more than 70, we consider as LFT is deranged. Okay, liver involvement or helps in elevated liver enzymes and low platelets. Okay, hemolysis, elevated liver enzymes, low platelets. All of them are important signs. I hope you can see me and hear me now. So I think I'll continue from this slide. Okay. Send me a thumbs up if I can continue from this slide. If I'm audible and you can see me and hear me now. Is my audio visual okay? Yes, I'm back. Okay, Shivam has given me a good to go sign. Yes, we are continuing with the investigation. As I've told you, serum creatinine levels more than 1 says it as renal involvement is there. Platelet of less than 1 lakh, yes. Thrombocytopenia or maybe chance of developing HELLP syndrome. And if liver enzymes are raised, as I was telling you, liver enzymes are raised. Normally, the liver enzymes should be less than 35. Your AST, all the things should be less than 35. But if they are more than double, okay, it's double. It should be more than double. That is more than 70 is considered as abnormal. Let us take, they give you 40, 45 values. It is not abnormal in pregnancy. Okay, if it is more than double, then you consider it as the LFT is deranged. Okay, then your prolonged coagulation time, increased chance of DIC, especially if there is case of PIH abruption because of hypertension. In such cases, clotting time and coagulation factors are really deranged. And increasing uric acid, it is also used initially it was considered as one of the early biochemical marker for preeclampsia, but it did not prove much well, but we did not use it further. Okay, now we have better markers like Doppler, isn't it? So we do not use uric acid as such for a marker. So coming to the fetal monitoring per se, so here we'll do daily fetal movement count, ultrasound with Doppler. Dopplers are more important for because we do not want fetoplacental insufficiency. There may be placental constriction or small placenta, fetal blood flow is not going well to the fetus, isn't it? So fetoplacental insufficiency is well assessed by Doppler. So hypertensive diseases, Doppler is a must. Okay. Then ophthalmic changes regular and routine, at least trimester wise, you should do a fundoscopy for all hypertensive and GDM patients. Okay, it is a must. So look for hypertensive retinopathy changes or in hypertension and GDM changes in diabetic retinopathy changes in diabetic patients. Okay, sudden reduction in fetal movements or abnormal fetal heart rate patterns may indicate uteroplacental insufficiency. Okay, so that is why whenever a patient walks to you with reduced fetal movements, first thing you should do, okay, let us tell give you a history now a patient has walked to you, she has 36 weeks, sir. Okay, 36 weeker to you, and she's primary gravida. She says my baby is not moving well from last night, sir. I'm feeling very anxious. Okay, she has come, she has no other comorbidities. What do you do? 36 weeker come to you with reduced fetal movements. What do you do? What is your first step? Yes, what is your first step? Mm-hmm. Reduced movements, 36 weaker, no comorbidities. Or say, let us say that she has comorbidities also. Then, first step, liver enzymes. Is this answer for this? Doppler, first step. That's what I'm specifically telling. First step, first step, first step. Mm-hmm. You should check for the fetal heart rate. You do the examination, isn't it? The first step is you will check either with a stat or with the Doppler, fetal handheld Doppler. You will check the fetal heart. First, you should check with your stat whether fetal heart rate is there. First, you know whether heart rate is there. No, then you will do the further investigation, isn't it? So you let us say in the exam they've given you, you have checked her heartbeat. Heartbeat is normal. Okay, she has decreased fetal movements. You check the heartbeat with your stethoscope or handheld Doppler. That time you have checked and it is saying as 140 beats per minute. What do you do now? next step. So first step is over. What is the next step? Yes, very good, Madhu. So the next step is CTG. So first you will check with your stat or your handle Doppler if you're not confident with the stat. Handle Doppler. Second step is your CTG, correct. So first you will do check with your stat, then you will go for CTG. Okay, CTG also is normal. Then you should still do an ultrasound for her. Why did she have this reduced fetal movements? A person who was always having good movements, why suddenly she had a reduced fetal movement? Still, you should do a scan. If it is no comorbidities, just a scan would do good. Just look for the liker if there is oligohydramnios developing or what. Is that the reason why she is having reduced fetal movements? Or if she is having comorbidities, you should also do Doppler to look for the fetoplacental insufficiency. Okay, very good. So, see, the exam question on hypertension may be n number of things. Okay, they can give you any number. I cannot tell you cannot tell, or nobody can tell this only will come. Okay, they can formulate a question any number of ways. So, what should be your objective? What is the first step? What is the next step? What is the best step? These are the questions they twist on. Okay, so remember, all of you, especially Suresh. Okay, so you know the answer, but Suresh, remember, since you are in a very hurry to answer, you might not pick the correct. The first option will be usually the closest one. So you might in a hurry pick it. Okay, so you calm down, relax, read, and then answer. So since you have negative marking also, and once your the 30 minutes or 40 minutes of time is gone, you cannot come back to it also. The first go when you read the question carefully and answer it. Okay, so this gives you a very good score in your exam. Read it carefully. Whichever comes, if you're not sure of the answer, whichever comes first will be the most common answer for you. Okay, so now coming to the objectives, whatever history they've given, what you want to do next? First is stabilize her hypertension. If they've given her PP is very high, what you want to do? Send her for scan, render investigation? No, stabilize her first, control her BP, give antihypertensives now. First option will be antihypertensives. Then is to prevent complication. What? Like abruption, eclampsia, prevent eclampsia. What do? We give magnesium sulfate, isn't it? So let us say they have given you history saying headache is there, blurring of vision is there, and her BP is 160 by 100. Okay, so like that history they've given you. What would you do now? First, you will give her antihypertensives. So if there are imminent signs, first you will give magnesium sulfate and then antihypertensives, both simultaneously hand in hand. Okay, so a magnesium sulfate becomes first the drug when there is high signs of imminent eclampsia. When there is no imminent eclampsia, just hypertension, then you will give antihypertensives first. Okay, deliver the healthy baby at optimal time. So now you know she's hypertension, now you know she's a complicated case, so you will plan her delivery at the correct place and time. Okay, restoration of healthy mother and the in the puerperium. So make sure she's monitored well in her puerperium. Make sure she's well organized and taking her antihypertensives. Whether you have to reduce or change drug, everything. Okay. So coming to the dosage of the drugs and action. So I'm sure you've read all these things in multiple platforms. You've read all these things all the time. So this also I request you to take a screenshot and also paste it somewhere so that you read it repeatedly and you take a good note of it. Methyl dopa is no more used. Labetalol is the first drug of choice. Since books are everywhere, it is saying we write methyl dopa. But remember, methyl dopa is not even available in the market. Okay, so labetalol is usually the first drug of choice. But why do we not give methyl dopa? What is the side effect? Why do we not give? It causes postpartum depression. So we are usually delivering pregnancy with hypertension soon, isn't it? We do not wait them till 40 weeks. Once the fetal maturity is attained, we'll deliver. So immediately after that, they'll have depression, postpartum depression, and even neonatal effects are there. So that's why neonatal methyl dopa is not usually preferred. Okay, but still, if there is a question, no other option, you can use that. But if there is an option of labetalol, definitely use that. Mechanism of action of all the three you should know. What is the maximum dose of all the three you should know. Okay, these are the important things. Should I clear the page? Do you want to take a screenshot of this? So these are all memory based questions, not much in this, so I'm not much stressing on this. So since you can read this and repeatedly and recall this in exam also. Okay, next coming to the emergency management. Okay, so now they have given you history. 160 by 110 is a BP. What do you want to do? First is stabilize the BP, isn't it? Then, so stabilizing BP in case of a in case of severe hypertension, what all you'll use? First is labetalol, IV labetalol. IV can be used labetalol. Onset of action is 5 minutes. Dosage, how do we give? 20 mg IV, 20-30 minutes, then double. So you can remember 20 mg, 40 mg, then 80 and 80. Okay, so 300 mg is the maximum dose, but 330 also we used to give initially. So 20, 40, 80, 80. This is per day. Maximum dose what we have given is per day hisab se. Okay. So 20, 40, 80, 80 it is. Okay. Yes. Then is nifedipine. This is oral drug, which is 10 minutes onset of action, which you can use after 30, 40 minutes. We can repeat. That is, you can give 10, 20, 30 mg and maximum of 120 mg. Hydralazine is again a drip set, infusion drip, where you'll give 10 minutes is the onset of action. Here, 5 mg every 30 minutes you can taper, you can start, and then you can maintain a dose of 10 to 20 mg orally or repeat in next 30 minutes. Infusion at the rate of 0.5 to 10 mg per hour you can give maximum. Okay, this is the maximum dosage you can give. Remember the recent trend, so much it was there about nifedipine, nicardipine. So nicardipine, though it is mentioned recently, it is not so much in the market, or availability is not so much. So nicardipine is only used for crisis, okay, not in case of normal. Okay, normal hypertension, let us say 150 by 96, 150 by 100, something like that was there. You don't need to use on OPD basis. You cannot use also. Nicardipine is only IV, and it is only for a severe case of hypertension, not for a normal case of hypertension. Okay, this much you should remember. So nicardipine dosage you can remember for exam, that is 1.5 milligrams per hour. Maximum of 6 milligrams per hour can be given. Okay, this is the nicardipine dosage. If asked in exam, since it is recent inclusion, may be there. That's why I've written in red and highlight. Again, I'll clear the screen. You can take a screenshot and make sure you read it for your exam well. Paste it somewhere and read it for your exam with the maximum dosage, and you will answer in your exam. Okay, the main aim is to answer in the exam here. Okay, so now you will arrange for me the correct steps in this. Which one you will do first? Okay, so preeclampsia management, BP is 150 by 100 for a patient. No other symptoms, no hypertension, nothing is there. Okay, what do you want to do? Which is the first thing you want to do? Yes, first is to control her BP. Yes, then is assess how the baby is, monitor the fetus. Yes, then is ensure good rest and high protein. She's losing protein, proteinuria is there, no? So this will become the third one. And then finally plan her delivery when indicated at an appropriate place. Okay, this is how you will arrange. This is how will you organize. This is how you will answer in your exam. Make sure you read the question, repeat and read. When the first time you're reading it, take your time and read it slowly and comfortably, so that you will assess every single point. That 3 hours of your time is going to decide your future, which subject you're going to take. So if you are interested in some clinical subject like OBG, definitely you should maintain a good patience of those 3 hours. Okay, so that is the key in the exam, not the one who studied maximum passes. Okay, it's a good rank. The one who had good amount of focus in the 3 hours. Okay, everybody has read, everybody used the same platforms, everybody has read the same thing, isn't it? Why is that somebody is getting more and somebody is not? It is only how they revised, how they recollected, and how they focused on those 3 hours. That 3 hours matters. Okay, so coming to the control of convulsions. So here, let us say hypertension with imminent signs or with seizures itself. So imminent signs, what are the sorry. So what are the imminent signs? Imminent signs of means what? Anytime soon. If you do not treat her right now, she'll go through seizures in front of you. Okay, she has come. She's telling, doctor, I'm having so much headache and not able to bear it. And you check her BP is 160, 110. So if you do not treat her at this moment right now, in next 5 minutes, she's going to throw you seizures. Okay, so here imminent signs are what? Headache, blurring of vision, and pedal edema. Pedal edema may or may not be there also. Headache, blurring of vision, nausea, vomiting are the key features. Pedal edema usually there also. With these things, pedal edema is there. You definitely think, oh, she's having hypertension. I'll check her BP first and I'll give her magnesium sulfate. Should be running in your mind. Okay. So the drug of choice here is The purpose is to control and prevent recurrence of eclamptic seizures. Drug of choice is magnesium sulfate. It is a CNS depressant, stabilizes nerve cells. Mechanism of action, there are four important mechanism of action. May or may not ask, because recently they're not asking memory based questions. Mostly it is clinical scenario, especially in clinical or clinical based questions can be given in such topic. No, that is why. Causes like uterine and cerebral vasodilatation, improves blood flow and acetylcholine release, reduces the acetylcholine release and reduces convulsion risk, safe for baby at a therapeutic levels. Okay. So why is magnesium sulfate used for seizure prevention rather than conventional anti-epileptic drugs? Yes. Why? Because here it is not a epileptic episode that is happening. It is because of neurogenic, that is the acetylcholine release, increased acetylcholine release, or the neuromuscular transmitters have been increasingly stimulated. That is what you have to stabilize, which magnesium sulfate has the best mechanism of action. Over to that, magnesium sulfate is safe at the therapeutic levels. It also helps in fetal maturity, isn't it? We give for fetal neural development, we give magnesium sulfate, especially in preterms also we give, isn't it? So we have dual action here, that is why. Okay, we prefer magnesium sulfate and not the conventional anti-epileptic drugs. So coming to the regimens, which has been conventionally asked multiple times, there are enormous times this question has come. So Pritchard regimen and Zuspan regimen. So Pritchard regimen, we have IM and IV, whereas Zuspan is only IV. So if they have given you a specific regimen, what is the specific loading dose? So most commonly asked is Pritchard regimen, which is both IM and IV, isn't it? So here we have two things. One is a loading dose, one is a maintenance dose. In loading dose, we have both IV and IM. So in IV, how much we give? 4 grams. Whereas in IM, how much we give? In IM, we give 10 grams. That is 5 on each buttock. So in total, loading dose will be how much? This is the commonest question. I think n number of times so many people would have asked you. That is 14 grams. And remember, magnesium sulfate is in grams. So they will confuse you. 14 grams, 14 milligrams. For 10 grams, 10 milligrams. Or 4 grams, 4 milligrams. These are the common confusion. Magnesium sulfate is in grams. And the loading dose in Pritchard regimen is 14 grams. This you should remember. Okay, 4 grams IV and 10 grams IM. This is a must know. There is no choice that you do not know. Whether you take OBG, you like OBG, or you want to do OBG or no, is secondary, you should know this. Okay, as a doctor and also as a NEET PG aspirant, this is a repeated question. Coming to the Zuspan regimen, here we give only IV, that is 4 to 6 grams of IV magnesium sulfate. Okay, so here both IV is always 20% dilution, IM is 50% dilution. This also you should remember. Coming to maintenance dose, in Pritchard regimen, we give 5 grams every 4th hourly. 5 grams every 4th hourly on alternate buttock. Let us say now at 12 o'clock you gave it at right buttock, and next at 4 o'clock you will give it left buttock. So initially loading dose we would have given on both the buttocks, right and left, isn't it? So next you will choose at 12 o'clock whether to give right, and 4 o'clock next you will give it left. That is how you will give. Okay, so now coming to the Zuspan regimen, 4 grams IV loading you will give, then 1 to 2 grams hourly you will titrate. So when do we prefer Zuspan regimen over the Pritchard regimen? Let us say they have given you a history saying she is a preeclampsia, imminent eclampsia is there, you tested her blood levels of platelet is 80,000. Okay, blood platelet count is 80,000. So you want to give, she's having headache, blurring of vision, imminent signs. So you want to give magnesium sulfate. You have decided you want to give magnesium sulfate. Which regimen would you choose in this patient? Okay, whose platelet count is 80,000? Which regimen you want to choose? So preeclampsia, imminent eclampsia, platelet is 80,000. So you want to give Pritchard's or you want to give Zuspan? Yes, you will answer. I'm waiting. This question too, I'm really excited. I think I'm expecting you to give a good answer in this. Which regimen you would choose is the question. So the dose, everything, I'm sure you should know. 14 grams is the loading dose in Pritchard. This is even in sleep, if I wake you up, you should tell. The loading dose is so much, and this is how we will give. Okay, yes, let me see who will answer me the first. whether we give Pritchard regimen for this patient or we give Zuspan regimen for this patient. Shruti or Shrutra. Shrutra. Okay. One answer is there for me. Anybody else? Mm-hmm. Okay, nobody wants to take a guess. Shruti, okay, we'll continue with Shruti's answer. She says that Pritchard regimen. Okay, remember Shruti, it's not like that. I'm sorry if I'm spelling your name wrong, but yes, it is not Pritchard's, it is Zuspan. Why? When the platelets are low, we do not give IM injections, isn't it? So why we do not give IM injections? There is high chance of hematoma collection anywhere. Platelets are low, isn't it? Whenever the platelet counts is less, we do not give IM injections. But in case of Pritchard's, there is a high dose, almost 5 grams we have to give in IM and 10 grams in both the buttocks. So in such cases, we do not give a IM injection. So that is why Zuspan is there. Whenever there is low platelet count, if your history or somewhere suggests that platelets are low, that means in such cases, we do not give Pritchard's. Good that you answered wrong, so that you answer in exam correct. Okay, main aim is exam, isn't it? So coming to the magnesium levels and toxicity. So magnesium therapeutic range is how much? 4 to 7 milliequivalents. So toxic signs are what? Loss of deep tendon reflexes. This is the first thing. And then is your respiratory rate. What happens? It reduces. Okay. Upon time, it will reduce the respiratory stimulus, hemorrhage. So magnesium sulfate. So there is very high chance that respiratory rate is going to reduce. Urine output is going to become less than 30 ml, and severe cardiac arrest can happen when there is excess. Okay, so whenever you are giving a magnesium sulfate for a patient, the important things to monitor are what? First is First is deep tendon reflexes, then is your respiratory rate, third is your urine output. These two, because it causes complication, whereas urine output of less than 30 ml means because magnesium sulfate is excreted through the urine. It doesn't cause renal damage or doesn't cause any harm to the renal tissue. What it is, because it is excreted through the renals, since there is no good amount of excretion here, that makes it what? Yes, that makes it toxic. The levels are getting accumulated in the body. Whenever the urine output is more than 30 ml, that means yes, it is going off. We don't have to worry much. It is going off, so we can give the next dose. When urine output is less, that means magnesium sulfate is accumulating in the body. Then the toxicity will develop. So that is why we do not give the dosage. So these are the important things to monitor. Okay, this is a must know question. There is no chance to not know this. Okay, this is again a must know question. So coming to the magnesium sulfate levels, we told 4 to 7 milliequivalents is the therapeutic range. Here nothing will happen. It is a good and gives relief from eclampsia or even imminent eclampsia. So coming to the why we are so scared to give magnesium sulfate, why do we monitor so much? Not other drugs, labetalol, we're not monitoring. Why? Because it is a short therapeutic range. 4 to 7, it is all good. But if it becomes 7 to 10, a slightly more, then loss of deep tendon reflexes are there. 10 to 12, respiratory depression will happen. Respiration is not going to happen. Respiratory rate is going to reduce less than 12, and then if it is more than 20 or 24 in the body, then there is high chance of having a cardiac arrest. Okay, this is the reason why we do not want to give magnesium sulfate without monitoring. Okay, monitoring is very important. So this is about magnesium sulfate. Coming to the antidote, let us say you have given off by somebody, your junior has given off extra, and what you will do, see is come and tell sir, deep tendon reflex is not there and her respiratory rate is only, I'm feeling 10 to 12, sir, what to do now? So you will tell, first, stop magnesium sulfate. Okay, stop magnesium sulfate immediately and start the antidote. What is the antidote? Yes, it is calcium gluconate. Calcium gluconate 1 gram IV, that is 10 ml in 10%. Okay, this is the antidote. Then support airway and monitors if a respiratory depression all is there. So support the airway and monitor the vitals. Okay, so this clinical study, you will tell me the answer. A 26-year-old primary gravida, 34 weeks period of gestation, BP of 160 by 100, pedal edema, headache and proteinuria is there. So what is your diagnosis? She is having proteinuria directly they have given. So instead of proteinuria, they might have given as platelet is low, or LFT values they could have given, or they could have given creatinine levels they could have given. So many things they could have given, isn't it? So anything they give you, you will answer. She becomes a case of preeclampsia since she's also having headache with imminent eclampsia. Okay, she's not having seizures, so she's not eclampsia. Imminent eclampsia. What is the drug you use to for seizure prophylaxis? Yes, tell me what is the drug you use? It is MgSO4. This is the easy answer. What antihypertensives can be given? Since it is acute emergency or a headache and all is there, you can give initially IV followed by oral. Okay. If patient is comfortable, you can give oral nifedipine also. Okay. What is the preferred mode of delivery? Yes. For all hypertensive patients, preferred mode of delivery, or what we want to do is what? Always vaginal delivery. Okay. It is vaginal delivery, not cesarean section. Okay, unless until otherwise indicated, we do not do cesarean because they deliver very fast. Okay, the compared to normal patients, hypertensive disorders patient deliver very fast and quick. They respond to medications also very well. Okay, so that is why we prefer to do hypertension patients deliver vaginally. Okay, so answer. Thank you, Amrita Varshni. You appreciated it, my efforts. And Shruti, again, correct answer, correct answer. Preeclampsia, I'm sure everybody would have answered. Headache, I had given. I was expecting somebody would tell imminent eclampsia also. Okay, yes. So, magnesium sulfate. So, this is a very simple case. Now, you will answer me this NEET PG 2025 question. Okay, yes. No, Shruti, it is not by LSES. We always try and deliver hypertensive patients vaginally. Baby is also small and they respond to the medications very quick and nicely. Okay, so almost all hypertensive patients are delivered vaginally. Even if it is an abruptio placenta, minor degree where maternal compromise is still not developed, we try and deliver vaginally because it responds very well, and with contraction, abruption also reduces. Okay. Okay. Coming to this NEET PG 2025 question, a patient with preeclampsia started on Pritchard regimen of magnesium sulfate. What is the total amount of magnesium sulfate as the initial loading dose? Okay, so loading dose will have, I've explained you many number of times because students get confused. That is why, again, I'm telling loading dose is having in Pritchard's IM and IV. So you will tell me what is the answer in this question. Yes, this should be a very fast answer, very easy answer it is. It is really scoring. Hypertensive disorder questions, if you get, it is really scoring. You will know the answer also. You will be able to answer easily also. Yes, very good. Shruti gave me the first answer and correct answer. That is 14 grams. Yes. Now you are coming to the track. So reading the question is very important in a clear terms that you understand in the first go. Next question. A 31-year pregnant patient was diagnosed with deep venous thrombosis after presenting with unilateral calf pain and erythema. Okay, so she is having DVT. There is unilateral calf pain and erythema. What is the most appropriate pharmacological agent in her acute management? Rivaroxaban, warfarin, fundoparinox, and low molecular weight heparin. Yes, answer me in this. So DVT, the drug of choice is usually heparin followed by low molecular weight heparin. Okay, since heparin is not there or unfractionated heparin is not there, then already there is a diagnosis of DVT. First you will give unfractionated heparin followed by low molecular weight heparin. Okay, this is the answer. But here it is not there. So correct answer would be low molecular weight heparin. But for your information, you should know if there is pulmonary embolism, there is a embolus, there is a clot already there. That time we initially give unfractionated heparin to dissolve the clot, then continue with low molecular weight heparin. When we are suspecting somebody will develop a clot, then we will give a low molecular weight heparin. Okay. So here correct answer is correct. It is low molecular weight heparin. So this is about hypertension. If you have any doubts, you write it down on a paper. After the end of the class, we'll discuss. Since the time is up, many students might want to leave or start studying their own subjects. I understand. And GDM is only left. GDM, I have very few slides just for your information so that since easy clinical based question scenarios can be made here. I'm expecting a question here, and we know diabetes capital is India only, isn't it? So that is why. So DIPSI screening is the recommendation. So when do we do DIPSI? One is at booking and one is at 24 to 28 weeks. Even if it is at booking, it comes negative, you will do at 24 to 28 weeks. At booking, if it comes to positive or GDM is diagnosed, then will you do at 24, 28? No. So one positive value is enough to categorize her as a GDM patient. You don't have to repeat it. So here you don't have to repeat it. She is already a case of GDM even if one value is positive. Okay. If negative, you will repeat it 24 to 28 weeks. So these are the important values that you should know. What we follow in India as a universal is DIPSI. This you should know only, where we give 75 grams non-fasting. Okay, this is a non-fasting. Patient need not come in fasting in DIPSI. Anytime she comes to you, let us say she has come to you at 2 o'clock to the OPD, you will give her 75 grams glucose. She'll drink it 2 hours later. We don't take initial value at all. See, you can see no initial values. Only after 2 hours, you'll check her blood. If it is more than 140, you will diagnose her as GDM. Okay. And in IADPSG, here what we give, here we want patient to come in fasting. She'll come early morning. First, you will take the fasting sample. Then you will give her 75 grams glucose. Okay. All it is 75 grams glucose. Only in ACOG, Americans do this 50 grams followed by 100 grams. Okay. So we follow only 75 grams. So you should remember mostly questions will be on 75 grams itself. So in IADPSG, patient comes in fasting, you will take a fasting sample, then you will give her 75 grams glucose to have, then you will check at 1 hour if it is more than 180 or 2 hours if it is more than 153. Whereas in WHO, which was initially there, now we do not follow, we either follow DIPSI or IADPSG. Here it is 92 and 140. There is no 1 hour value that is tested. So these values are important. Remember for your exam. They might not ask you what is the value. They will give you a value and ask you to diagnose this. I have a question also for you similarly. Okay. So now you will tell me. Now we diagnose GDM. So how do we differentiate whether a patient is GDM or overt diabetes? So first time detection in pregnancy, is it GDM? Let us take at 12 weeks you did OGTT. It came as 150. Okay, DIPSI came as 150. Is she in first trimester diagnosed? Is she GDM or overt diabetes? That means who's already pregnant, is already diabetic, has got pregnant. Which is she? Yes, you will answer me this for sure. You should answer this question. 12 weeks pregnant patient, you did DIPSI and second R value is 150. Is she GDM or is she over diabetes? Mm-hmm. Amrita Varshini. Yes, give me the answer. Shruti also gave, Suresh also gave. Okay, I didn't see, sorry. Diabetes, what does that means, whether she's overt or GDM? Okay, remember, in just like in hypertension, in GDM there is no weeks classification. It is only on based on the sugar levels. Okay, it is not based on her weeks. Even if it is detected first time in pregnancy at 12 weeks, 8 weeks, 10 weeks, 20 weeks, any weeks. Okay, if the values, based on the values you will decide whether she is overt overt or whether she's GDM. Like in hypertension preeclampsia, we have no, it is after 20 weeks. Like that, we don't have in GDM. So don't get confused with that. Okay, this is what I was trying to tell you, and you have all of you have given the same answer. It is overt, but 150 is a GDM patient, not a overt patient. So for an overt patient, fasting should be more than 126. If HbA1c is, they have given you values of more than 6.5, and if there is more than 200 values of after sugar or any value of more than 200, then you consider as a her as overt. Okay, it is not based on her period of gestation. Okay, this is what I was trying to tell you. I hope you have understood. It is not overt. Okay, if her fasting value is more than 126, or if HbA1c is more than 6.5, and if any value is more than 200, be it second hour, post hour, any value comes more than 200, if they have given you more than 200, then those patients are called as overt diabetes. Okay. So coming to a pregnancy is a diabetogenic state. As we all know this, what are the key features for which by pregnancy? There is increased insulin secretion and also degradations. Insulin is secreting, but it is getting degraded also. And what does this human placental lactogen do? The sensitivity of insulin is reduced. Okay, progesterone, estrogen, all of them will reduce the insulin sensitivity, and also increased tumor necrosis factor also will reduce insulin sensitivity. So that is the reason there is increased secretion of insulin. So that though there is increased secretion, degradation also is there. That is why insulin doesn't act well in pregnancy. Okay, so that is why pregnancy is a diabetogenic state. One more thing I want to tell you, pregnancy, it is fasting hypoglycemia. Okay, fasting they'll be, because they're long standing no sugar intake, no. So fasting hypoglycemia and postprandial hyperglycemia. Okay, this also you should remember. Fasting hypo and postprandial hyperglycemia. Just like in hypertension, we read it as the flow is increase in resistance and reduce in flow. Correct? No? In hypertension, the resistance increases, the flow decreases. Here, you should remember fasting hypoglycemia and postprandial hyperglycemia. This question also they have asked. Next, coming to the obstetric management. So in GDM, you should do first, good control is there on MNT. So treatment is basically medical nutrition therapy. If it is borderline, otherwise not controlled, then you'll go for medical management, that is your metformin. And then if it is still not controlled, you can go for insulin. So this is the basic treatment. So if it is well controlled on medicine or MNT, then you can wait till 40 weeks. But if she's taking insulin, you'll try and terminate by 38 weeks. So remember, in case of GDM, we can do cesarean directly. When the baby weight is more than 4 kg, very high likely of cephalopelvic disproportion. That is why in GDM, if the baby weight, let us say they have given you case scenario, GDM is there, patient is on insulin and she's 38 weeks now, on scan estimated fetal weight is 4.5 kgs. What is the mode of delivery? Induction of labor, spontaneous labor, the cesarean section, patient's consent. Okay, these are the options. What would you choose? So since I told you if it is more than 4 kgs, in the scan I have told you weight is 4.5 kgs. So here directly LSCS would have been the answer. Okay, if the more than 4 kgs, it becomes very difficult. Not that we have not delivered more than 4 kgs. 4.6 also I have delivered, but that would be a normal mother. Okay, where in case of GDM there is excessive fat accumulation behind the shoulders. Okay, that makes us very high chance of shoulder dystocia, which we are discussing tomorrow. A surprise, good topics for you tomorrow, isn't it? So that is why shoulder dystocia we are discussing tomorrow. Hope to catch you all again in tomorrow's class. Come live and clear all your doubts. Okay, so this is the shoulder dystocia. Everything is discussed tomorrow. So there is very high chance of shoulder dystocia, difficult labor, injury to the mother and the fetus. That is why more than 4 kgs we usually do cesarean section in case of a GDM patients. Okay. Yes, correct, Amrutavarshini. It is elective LSCS. Treatment reduces macrosomia. Whenever we are giving metformin or insulin, our aim is to prevent complications like macrosomia, dystocia, stillbirth, preeclampsia, and cesarean section. Okay. So coming to the neonatal complications. So remember, important thing is this one: hypoglycemia, things which reduces, one is sugar for the baby after it is born. Things which reduces are sugar, magnesium, calcium. So hypoglycemia, magnesium and calcium are reducing. Things which increases are polycythemia and hyperbilirubinemia. If these two column you know, it is more than enough. So which reduces, which increases. Okay, and respiratory distress is very common in these patients. Other than those congenital anomalies, all those charts and all you have read. So this is what I wanted to tell you. So things which reduce post delivery is sugar, magnesium, calcium, which increases RBC volume and your hyperbilirubinemia. Okay. So ketoacidosis, the precipitating factors. When do maternal diabetic ketoacidosis happen? Whenever there is infection, steroids or labor stress, more chance of ketoacidosis. So you will assess the blood glucose, ABG, serum ketones, bicarbonates and electrolytes. So you can give, if they have given you any values abnormal, a diabetic mother in labor is having very high sugar, ABG they have given you abnormal or ketones are positive. What is your diagnosis? Diabetic ketoacidosis in pregnancy. Okay, this is how you diagnose. And for treatment, most important treatment is fluid correction. You give a good amount of fluids, okay, fluid correction, and then maintain the sugars between 100 to 50 and give insulin along with that. And also you will correct the bicarbonate and potassium levels and monitor fetal monitoring. Initially during diabetic ketoacidosis, for almost 4 to 6 hours, I think there is very high chance of fetal distress. Non-reassuring NSTs are very common. But once the ketoacidosis settles, the fetal distress also would settle. Okay. So in with diabetic ketoacidosis, increased perinatal loss also is there. Okay. So now you will answer me this question. With these two more questions, we'll end the live session. So you will tell me what is the answer for this NEET PG 2023 question. A 36-year-old, okay, I'll read it slowly along with you guys. Maybe I'm reading it fast, that's why I'm waiting for a long time to answer. So we'll read it slowly with you. 36 weeks pregnant women with GDM, 36 weeks she is. Breathlessness is there. Marked abdominal enlargement. Fetal movements are normal. On examination, fetal parts are difficult to palpate. You're not able to feel the parts. And the fetal heart sounds are present but muffled. And symphysiofundal height is 41 centimeters. Very high, isn't it? 36 only maximum. 41. And abdomen feels tense but not tender. It is tense and not tender. This we are going to discuss tomorrow. What is tender uterus? Okay, where do we get tender uterus? Most likely diagnosis. Yes. Yes, Madhusudan gave me the first answer. Very good. It is polyhydramnios. So in polyhydramnios, we don't feel the fetal parts. What happens in oligohydramnios? How do we describe it? Full of fetus. Uterus is full of fetus. This is how the description they would have given. Okay. So in poly, we cannot feel the fetal parts, and fetal heart sound is muffled, cannot be heard because of excessive liquor. Okay. Fetal parts are difficult to palpate and fetal heart rate is muffled. This makes you a more closer diagnosis. Association of GDM gives you a higher incidence of polyhydramnios, isn't it? So this is one of the important complications of GDM. So what are the important things? This is why we want to give insulin and maintain good sugars to reduce polyhydramnios, over distension, macrosomia. All these are the possible complications we prevent by giving insulin. Correct. Okay, very good. So many of you gave me the correct answer. Very good. So next question now. A 30-year-old primigravida at 18 weeks of gestation comes for her antenatal checkup. Okay. Her random blood sugar is 243, which says she was advised further testing. Her fasting is 146 and her HbA1c is 7.6, which is the most likely diagnosis. GDM, overt, latent autoimmune diabetes in adults, and maturity onset diabetes in, of young. Yes. Yes, correct, Danush Gowda, because you've given two answers. I know you have answered this question. Very good. The correct answer is over diabetes. As I told you, any value of more than 200 and fasting more than 126 and HbA1c more than 6.5 is considered as over diabetes. So the correct answer here is over diabetes. Okay. So this is all about today's live. We'll catch you tomorrow in the next live session where we are going to discuss about APH, PPH, labor and postpartum complications and end obstetric revision tomorrow. So if you have any doubts in obstetrics, we can clear it tomorrow or now also after this session. But before I conclude, I want to tell you, Diginerve has got you a great offer for those who attended the live session or seen this video. Only for you guys, we have got this revision course, not the full course. And mind you, just the revision course, just for only 799 rupees. You can just do the scanner. You can find very good lectures of Dr. Arijit Balu sir and Shuman sir, and anatomy and pathology, microbiology. Every lecture you can find just for 799 rupees, and do your quick revision of all the topics. Here I've just read the high yield topics. Since you have almost still 1 month time, just listening. Let us say when you're sleeping, when you're driving, when you're doing some other work, you can just listen and revise and recall in your exam. This will really boost your confidence in exam. Be calm and cool. You can do it. You will do it. Okay. All the best. Okay, let me see if anybody has any doubts. Okay, Madhusudan, topics for tomorrow are APH, PPH, labor, and postpartum complications. I'm mostly going to end obstetric things tomorrow. Whatever I could cover, I've covered it today. For tomorrow, these are the common topics, and day after I've kept for gynae. Okay. Danush Gowda, fasting more than 92 definitely is a GDM. For saying as over diabetes, it is more than 126. Okay, if a patient comes to you whose value fasting is 100, she is a case of GDM. Who comes to you whose fasting is, let us say, 146, as in this case, then she's a case of over diabetes. Okay, this is how you will differentiate between these two. Thank you, everybody. So let us join tomorrow. Thank you so much for your appreciation. I hope you liked it. It is more than liking. If you have to recollect and you have to answer in your exams, that is my main aim. I hope you'll answer in your exam and get really good rank and join your subject of choice, and it's a place of choice also. Okay. All the best. Do well. Okay. Okay, Shruti, I'll repeat the diabetes thing. Yes, it is when you have a diabetic values. Okay, let me tell you when these values I'll show. Yes, so here as I have shown in this figure, these values when fasting is more than 92, or 1 hour is more than 180, and 2 hour is more than 153, or your OGTT is more than 140, then it is case of GDM. Okay, this all is a case of GDM. Here we have just mentioned more than. So if it becomes too much, let us take your RBS, random blood sugar is 220. So is she till GDM? No, she becomes over diabetes. Okay, and let us take her fasting is 136. It is more than 126, isn't it? So that time she becomes over diabetes. So for diagnosing over diabetes, we have these three criteria. One is FBS, which is more than or equal to 126, and HbA1c, which is more than 6.5, and if any random sugar or any sugar value which is more than 200, then we consider them as over diabetes. Okay, we do not label them based on the period of gestation. Let us say in first trimester, in her first visit you did a OGTT, still it was fasting was 100, still she will be a case of GDM, not a case of over diabetes. Okay, and HbA1c values is significant only in first trimester. Later trimester HbA1c values are not significant. Why? Because there is hemodilution, so these values might be abnormal. That is why later gestation we do not use HbA1c, we use FBS and RBS. Okay, I hope you understood now. So there are no more queries coming up. So I think you have understood well and you'll answer in your exams. All the best, students. Let us stop sharing and you go and revise your work. Have nice dinner and you will start studying for your exam. Don't waste your time right now. Now is the time you will decide your rank. Okay? All the best. Okay, the tomorrow timings is same. 5 o'clock will start. I'll clear fix all the technical glitches today, and we'll sure start by 5 o'clock. By 5, you can join tomorrow. Okay, the same time schedule. We can keep it for tomorrow also. Okay. This full recording will be in the Diginerve app. I think I'll tell some technical team to contact you, and maybe you can approach them to get how to get this. Okay, I do not know directly how to share you these slides or get these information, but this full video will be available for you for any time revision. Even the notes you will get, the information, the information that we have made for the quick revision, that PDF, we will definitely share it to you in the Telegram group. You can join the Telegram group and definitely take the advantage of attending the live session. Yes, you will get those information in the Telegram group and the Diginerve app. Everywhere you will get that.